Hello, I'm Dr. Bari from Bangladesh. Now I'm working at the University of Tokyo, Department of Radiology, and here I am here for my PhD actually, and doing for the regular works that a radiologist usually performs, and I'm also working for some papers on cardio and neuroradiology. Anyway, I think chest X-ray is quite a common investigation that our clinicians, physicians usually advise the investigation to his patients, and this is a very vast information. There are quite a lot amount of information that we get from chest X-rays, and I am going to describe how to read a normal chest X-ray, and after that, I will try to present. I will try to show you some quite common abnormal cases that usually you can find in your departments and working with patients. Okay, then first of all, I should say there are some common modalities of evaluating the cases of chest, and the most common, as I said, the routine normal chest X-ray, and and if we are confused or if we need to go some little bit advanced, we do CT scan, and it may be contrast and non-contrast as well, and there are some nuclear studies of chest also. We can perform ultrasound if it is indicated. There are also fluoroscopy, and not so commonly done nowadays, and bronchoscopy is quite important sometimes, and we can perform pulmonary angiography, which is really very important, and bronchial angiography as well, and MRI. It's a brother of CT scan to me, I think. And we have needle biopsy also, and sometime lymphangiography, very rare, but not the least. And PET CT is quite not a new thing nowadays, and PET CT is also very important. Okay, what are the common views of the chest? Usually we advise chest X-ray PFU because it's quite easy, and almost always chest X-ray PFU gives us quite a lot of information, and sometimes we perform chest X-ray lateral view, it may be right or left, and we perform AP view sometimes when the patients are disabled or when we need to see the anterior portions of the chest. And not anterior portion, I think it would be posterior portion, sorry to say. Anyway, and there are decubitus views. I mean, when the patient is kept supine and in a decubitus position, and it also gives us quite a lot of information when discovering the dependent areas abnormalities. And before performing a chest X-ray or before reading a chest X-ray, a physician or a clinician should observe some common things. One of the common thing is either it is inspiratory or expiratory film. If the film is over inspiratory, some information may be missed, and if the image is expiratory, definitely some of the lung details, especially the details of the lower lobes, will be hidden at the liver shadow or the stomach shadow or something like that. And another position is lordotic view. Lord, you see a man almost standing. I don't think he is a lord. He is standing a bit artificial lord. Okay, and this view is performed to view the apical regions of the lungs. They becomes if we suspect anything spatial in the apical region. Okay, Rotation. I mean, when a patient should stand for a chest X-ray, he should be quite central or quite straight in position. And it's not our duty, that it's the duty of the radiographer. But how can we say that the patient is well positioned from viewing the chest X-ray? It's quite easy. You see the spinous processes here and the medial end of the clavicles, and the distance from the spinous process of the clavicles, medial end of the clavicles, are almost equal. So if we find the spinous processes equally if the distance is equal from the medial end of the clavicles, then you can say the patient is centered well, or the position is quite okay. This is important because sometimes the trachea appears to be shifted to the right or to the left, and we can make a misdiagnosis about the volume loss. And this one is also very important, especially for aged patients, because the exposure, this is not also a duty of the radiologist or the physician, but he have to know, he shouldn't make any misdiagnosis. Like, he should know whether the X-ray is overexposed by the radiation, or the contrast settings was low, I should say. And you see, this one is appears to be a bit white, and this one, the lung field, appears dark. So if it is more white, you can say that there are some lung infection or inflammatory changes. Or even if you see this one, you can say that the lung field is showing some kind of emphysema. So we shouldn't consider both of them as pathologies, because they're due to contrast settings or overexposure of radiation or X-ray, and the optimum one is this. So how can you know that this one is optimally exposed? The fact is, the vertebral bodies should have to be visible just behind the cardiac shadow, but not so prominent. Even the lower vertebral bodies, thoracic vertebral bodies, sometimes should not be viewed in plain chest X-ray, but the upper vertebral bodies should have to be seen clearly. So this is very important, and there are some cases of paravertebral soft tissue shadows, as you know. So this is quite important for evaluation, and you will not miss, I think. Okay, sometimes we say that the heart is enlarged. The heart is a quite common thing to look at, and this is not the correct style of measurement, the distance of the heart, because as you see on textbooks, that there should be a straight line, and then from the tip of the highest bulging point of the right heart border there should be another line, and from the highest tip of the left heart bulging border there should be another horizontal line, and the distance from this imaginary line, the total measurement would be the measurement of this line and the measurement of this line. So the total distance would be the summation of this and this, not straight cut this, because you see on this side this is not the highest bulging point of the right heart border. Anyway, so if this is the overall transverse diameter of the heart, and if this is the diameter of the chest, this is an eye estimation. We don't need any calculator. You have to make it just by viewing the image. It seems that this distance is less than 50% of this measurement. So the heart size is quite normal. This is if this is a chest X-ray PA view. But in case of children, or in case of chest X-ray AP view, this can be up to 60%. I mean, if the heart transverse diameter of the heart is 60% of this total diameter, then that is also normal. This is I am saying about the common things. And you see that about measuring this measurement, one thing is very important, that is the measurement should have to be from the medial margin of the chest wall, not from here. It would be from here, both sides. Okay, I think you can now measure and say either the heart is enlarged or not. There are some other factors by which we can say which chamber of the heart is enlarged. I will describe it later. And now you see, this is a quite common picture, usually available in almost all books. These are the aortic arch. This is a pulmonary trunk. Left atrial appendage, not so important, but for some cases, just forget them and just remember that there is a concavity, and the superior vena cava usually superimposed through this line. You cannot commonly detect the superior vena cava, and you can see the apex. As we see, this is the left side, so it should be left ventricle, and this is the cardiac apex, and usually the right atrium forms the right heart border, and the right ventricle usually the central part of the heart. The central part of the heart is usually the right ventricle. Either it is on the left or the right. The whole part appears actually the right ventricle, because you know the anatomical position of the heart. Anyway, this is just for a lesson. Okay, one more important thing is paravertebral soft tissue shadow. You see, if this is the tracheal shadow, there are usually more white areas on the right side of the trachea. This is quite normal. This is we call paratracheal soft tissue shadow. Sometimes when paratracheal lymphadenopathy occurs or any other cases like mediastinal widening, this area is widened. So this is quite commonly missed by the radiologist and the physicians. So of course, when you see the trachea, of course, don't forget to look at these areas, because this is very important. If there is widening, there are so many common pathologies that we find usually here. So for now, this is just paratracheal, right paratracheal area. Okay, we know it from our anatomy that this is the anterior mediastinum, this is the middle mediastinum, and the posterior mediastinum. Okay, this man looks quite handsome, isn't it? And I like his eyes and hairstyle also, and the white shirt. Anyway, this art could be. He's a quite good man and was a popular man. I hope you know him. He was Julian Assange, and he discovered so many hidden things are the politicians and so many secrets that shouldn't be exposed to the media or to the general people. Why I have included his picture here is he is some kind of exploring or discovering person, and explores the hidden things. So the doctors or the clinicians are some kind of Julian thing, like viewing the chest X-rays. You have to find out whether there are any hidden abnormalities. Special cases I am going to show you. You see, these are the hidden areas: the apical region, the heart, and the subdiaphragmatic region. Consider that most of the ribs are almost crowded at this region. So these areas, when you look at these areas, mostly you see the bone things. I mean the bones, and the lung fields are quite obscured on the apical regions. And of course, this is not to mention that behind the heart, or in front of the heart or around the heart, there are some portion of the lung fields. So they're also obscured by the blood, which is showing as dense homogeneous areas. And if the patient is even well inspirated, under the diaphragms there are lung fields, if you can remember the lateral view of the lung or the anatomy of the lung, it goes behind the areas. Behind these areas are also lung fields, but unfortunately we always do not look at these areas. Sometimes we consider this one is a fundic shadow and this one is the liver shadow, so that's all. But this is a very common thing that we miss. So for clinicians, I hope if you look at these hidden areas like Julian essence, you can discover something to the society, I mean to your patient. Okay, the hidden areas. Apices, I told you, the mediastinum and hyla, and the diaphragm, I mean the subdiaphragmatic areas. Bones, of course. Bones covered almost 50% lung fields. So you see, these are ribs. These are ribs. So behind, in front and behind of the ribs, there are lungs, but they are usually missed, maybe missed. You see, if this is a nodular shadow, just going along the ribs, posterior end of the ribs, it may be missed. It cannot be so much prominent. I made it. I have created it with an artificial rounded shadow making with PowerPoint, but this may be a nodular metastasis. So some kind of nodular metastasis may be behind the ribs. So always try to look at the ribs if you consider that if you perform your patient's chest X-ray for searching metastasis. If you suspect that there may be some metastasis, even if the chest X-ray looks quite normal, you should search for the hidden areas. I think you can be a great doctor when you can discover something really exceptional and which can a busy radiologist miss. Okay, you see the more horizontal ends are actually the posterior end of the ribs, and the oblique ends are actually the anterior end of the ribs. So if you see any anterior oblique thing, you can say that this is the anterior end of the ribs, and if you see something horizontal, you can say that this is the posterior end of the ribs. Okay, now the big business, lungs. Lung has lobes, we know, like on the right side and on the left side. On the right side there are 3 lobes, on the left side there are 2 lobes. The lingular segment is the part of the left upper lobe. This is very important that we commonly miss. And zones, we have lung zones. Radiologically, excluding the lobar distribution, we have made the lung as zones. Like this is the anterior end, I said this is the anterior end of the second rib. So if we draw an imaginary line through the anterior end of the second rib, and which border, or superior border or the inferior border, it should be the inferior border. So if you draw an imaginary line through the inferior border of the anterior end of the second rib, the area above that line would be the upper zone, and from this line to this is the third rib, this is the fourth rib, this is the lower margin. If you draw another imaginary line at the inferior margin of the anterior end of the fourth ribs, so from this line to this line, these zones will be the mid zones, and the zones lower areas will be the lower zones. So the upper zones, mid zones, and lower zones, not the lobes. So this is quite easy for the radiologist to describe reading a chest X-ray. Okay, the CP angles, I mean the cardiophrenic or the costophrenic angles, both can be used, but in case of PA view, we usually use the costophrenic angles, the diaphragm and the chest wall. So this is the costophrenic angles. And trachea is quite important. You see, it's quite easy, the lucent areas, because they contain air like the lungs, and of course try to check either it is shifted on either side or not. And hemidiaphragm. Also in peer view or AP view, we can see the diaphragm quite easily, but lateral view is sometimes important in case of diaphragmatic hernia or something like elevation or depression, or when a pneumoperitoneum is suspected. We can't confirm that either it is pneumoperitoneum or something else. So lateral view is also very important, and sometimes fluid is also collected in the posterior CP angles. This is the most dependent part. Posterior CP angle, this is the anterior CP angle. So these areas, if they are not like acute, if they are blunt, so and with dense opacities, then you can say that there are some effusions here. And the sternum in lateral view, the basic thing is the sternum. Sometimes it is depressed, sometimes there can be some bony metastases or bone reductions or some bone tumors or even fractures. So sternum is quite important, and the area behind the sternum, this area is called retrosternal area, common name, and this area behind the heart shadow is called the retrocardiac area. So retrosternal and retrocardiac area is also very important. So in case of lateral view, we usually see the vertebral column, the sternum, the anterior and posterior CP angles, and the retrosternal and retrocardiac areas. Okay, these are the CP angles, and you see the right hemidiaphragm is usually a bit higher than the left hemidiaphragm. This is very important. I'm gonna describe it now. So when you will say that the right hemidiaphragm is elevated, if the distance from the left to right is more than 3 centimeter, I mean if the right hemidiaphragm is elevated more than 3 centimeter than the left, you can say that the right hemidiaphragm is elevated. My question is why the right hemidiaphragm is normally elevated than the left? Because the left side contains the heart. So due to the load of the heart, the left hemidiaphragm lies slightly lower. Never say that due to liver, the right hemidiaphragm is upwards. Liver, due to gravity, doesn't go upwards, isn't it? And the convexity, I mean the dome shape of the diaphragm, is also very important. When we say that the highest point from the convexity and another imaginary line from this point, I mean the starting of the diaphragm to this point ending of the diaphragm, there should be a straight line, and if we measure this one and if it is not more than 1.5 centimeter, then it's quite okay. And if it is more, then we can say there are some muscular weakening or humping or some kind of hernia or maybe anything else. So that's quite important. I think you shouldn't need to measure them. Just look at the x-ray and you can imagine what's gonna happen. Okay, the left hilum is usually upper in location than the right hilum. You see, this is quite normal because if you can remember the development, that usually actually the left principal bronchus is the direct continuation of the trachea. So so this one is appears higher, and then the branching came on the right side. Okay. Another point is you have to see either the hyla has both hyla has same density, because hilar lymphadenopathy is quite common. So if they have got the same density, then you can say that the hyla is normal. Okay, and the hilar angle, this is if you see that there are some vascular expressions going upwards and there are some vascular expression going downwards. Also on this side there are some vascular expression going this way and someone going this way. So if you draw an imaginary line this way, and this angle is the hilar angle. This is very important because when there are some abnormality, the angle is not maintained, or the angle is blunt, or sometimes they are widened or something like that. I will discuss it when I will discuss about the pathological cases. Okay, as I described that this area is named as retrosternal area and this area is called the retrocardiac area. This is quite important because some lung lesions may be missed, the hidden areas. So this is very important that you should remember these are the hidden areas. And in lateral view, sometime in a normal chest x-ray, in lateral view we can discover the hidden thing like this. So never say viewing a normal x-ray that the chest is normal. I should recommend almost always there should be a lateral view if you really want to evaluate the lung and chest case properly, if you don't have the facility for CT scan. Okay, so the key points are the central hierarchy structure. This is not quite common. I don't like this picture, and I don't measure this way. But I have to include it. The pulmonary trunk, the larger circle, and the right upper lobe bronchus, left upper lobe bronchus, and the pulmonary artery as well as the aortic artery. I think viewing so many frequent X-rays in lateral views, every clinician can imagine at the level of these instruments. Okay, this is very important. You see the pulmonary vessel is going this way, and there are some, it looks like calcifications, but they may be something like pulmonary vessels in end-on view. They are vessels. Why I am calling vessels? Because vessels contains blood, and the blood definitely they will be white. They will not be black. If they're bronchus or something like that, or any branch of that, they should contain air, and they should look dark. Okay, so these are not Carly's lines. So they are vessels. This is the common sense because they contain bloods and they are looking white. Just end on view. End on view is you are looking on a pen from its tail. This is end on view. Okay. I told you that this is the pulmonary artery, but I didn't told you the diameter. If this is a margin and if this is another margin, if you measure this line, if it is within 16 or 15 millimeter, then the pulmonary artery diameter is normal. This is very important. But the point is, from where you will measure this distance? Will you measure it here or here or here or here? I told you about the hilar angle. That means one segment is going upwards, one segment is going downwards. So from hilar angle, just if you measure 1 centimeter or 2 centimeter, as far as I can remember, it could be 2 centimeter. I'm not sure. Okay, not more than 2 centimeter. And here you will measure the distance of the pulmonary arteries, and it will be 16 or 15 millimeter. If you find it is more than this, then there should be some kind of pulmonary hypertension, whatever may be the cause. This is very important. Most of the radiologists do not include pulmonary hypertension, and pulmonary hypertension can lead changes in the lung fields, changes in the heart, and even the clinical features, as the clinicians knows much better than me. So this thing is very important, but usual radiologist looks only at the bones and the lung fields. The hila, the pulmonary vessels, the heart, these are quite detailed information that we usually do not find in the reports. Okay, end-on vessels. I told you that the white spots are like end-on vessels, and they contain blood, so they are white. And these are the anatomical pictures showing you the lung lobes and segments. I don't like to describe this image, even I can't say them closing my eyes. I would like you to forget these stupid images. And respiratory unit, I studied from my physiology when I was a first year MBBS student, so I like the grapes, but I don't like to describe the picture. Lymph nodes. There are some common areas that can be affected, and the lymphadenopathy can be found. You see the parasternal lymph nodes, as I said, usually they're more on the right side. I told you to look at the right paratracheal shadow for these things. And there are some tracheobronchial nodes, carinal nodes, this is very important, and bronchopulmonary nodes. I mean, look at the hilum. That's the main business, and the right paratracheal shadow. Okay, Shiloty sign. This is very important. Shiloty, I didn't know the word, especially the spelling was peculiar, but I found that it's nothing but a shadow. I don't know why they use some stupid words. They want to make them a big scientist, I think. Or anyway, design is if you see a lesion around the heart border, but the heart border is quite visible, then sign is negative. But here you see the lesion have attachment, is close to the right heart border, but you cannot define the right heart border quite clearly. So in this case, you have to say Chilote sign positive. So if the lesion obscures, deletes the clear margin of the heart border, it means it is that specific lung segment located with heart. So usually they are the medial segments. This is a common sense. And of course, the middle lobe of the right lung is also attached, in close relation with the right heart border. So if you find this lesion, it means it's not just the segments which is close to the heart. So it must be anterior or posterior to the heart. Okay, and if you find this lesion, then you can clearly you can clearly segmentify or describe the specific segments of the lungs without observing the CT scan. Most of the radiologists usually say this kind of reports like pulmonary inflammatory changes of the right mid-zone or something like that. I don't like that. They should describe which specific segment of the lung is affected, because in that way the clinician can differentiate his business with the patients. Here you see the left heart border is quite clearly seen through the lesion. So it's not Chilote sign, it's a Chilote sign negative case. And vertebral translucency. What should be the vertebral translucency in lateral view? I said you in PA view they should be just visible behind the cardiac shadow, the lower ribs, lower vertebral bodies. But in lateral view, the lower vertebral bodies have to be clearly seen, but not the upper vertebral bodies. They would be gradually faded. So remember, this is the optimum exposure. When you can see the lower vertebral bodies rather than the upper vertebral bodies, it means the exposure is quite okay. You don't need to look the lateral vertebral bodies in the chest X-ray lateral view. The upper ones. Okay, what is companion shadow? In a normal chest X-ray, sometimes we find a double shadow like this one and this one. This is looks like another margin of the clavicle that can mimic like periosteal elevation. So be careful that this is normal, and almost always they are bilaterally symmetrical. Remember one thing, that if you get anything bilaterally symmetrical, possibly that one is normal if you do not know what that is. So if it is bilaterally symmetrical, just avoid it. Do your own business in that case. Okay, I think I have described enough about the common chest X-rays. Then I will show you some cases in the next presentation, and after that I will describe about the cardiac cases, especially the congenital cardiac cases and some of the normal pathologies which we usually find in chest X-rays. I hope you would enjoy, but I'm sorry to say that my English is not that much good. I am from Bangladesh and I am not from an English medium school. So please forgive me if you find any abnormal smartness in my presentation. I hope you'd like my next presentation. Okay, that's for now.